Welcome back to the deep dive. Today we are taking a deep breath and a scalpel to one of the most immediate high-stakes fields in medicine, the management of torso and pelvic trauma.
Hmm.
For those of you who need a shortcut to being immediately well-informed on surgical essentials, whether you're prepping for an exam, briefing a team, or, just intensely curious, we are focusing exclusively on the latest, highest-yield insights from the absolute gold standard.
And that is Bailey and Love's short practice of surgery.
Just exactly.
That's right. Our mission today is to really cut through the complexity and extract the core conceptual framework. We're not just summarizing anatomy here.
No.
We're trying to synthesize the strategic, real-time decision-making that you need to manage a trauma patient. I mean, this is all about mastering the practical application of restoring physiological stability when the clock is just violently ticking.
And when we talk about critical knowledge, we have to start with the stats that really define the battlefield. When people think of trauma deaths, they often picture severe head injuries, and, rightly so. Brain injury accounts for about 42% of fatalities.
It does.
Yeah.
But there is a massive and often hidden second killer.
And what's that?
That second killer is the entire reason modern trauma care exists as it does today. A staggering 39% of all trauma deaths are caused by major uncontrollable hemorrhage.
Wow. Almost as much as head injuries.
Almost. And the primary source of that massive bleed is almost always the torso. So we're talking the chest, the abdomen, and the pelvis. This deep dive is necessary because if you can't master rapid, targeted bleeding control in these regions, honestly, the rest of the trauma management protocols become irrelevant.
So let's start with that fundamental shift in thinking that has defined really the last few decades of surgical trauma care. Historically, surgeons were taught to repair everything definitively, to be anatomically perfect. But the source material makes it abundantly clear that this traditional anatomical focus, while noble, often failed. What drove that realization that actually physiology has to take precedence?
The simple reason is time. It just comes down to time. The traditional model where a surgeon would attempt a lengthy, comprehensive, and a definitive repair of every single injury.
Right, fixing everything perfectly.
Yes, and that often took hours in the operating room. So while the surgeon might achieve anatomical perfection, the patient was getting colder, they were becoming more acidotic, and their blood was clotting less effectively. They were entering what we now call the deadly triad.
So the anatomical approach was actually killing the unstable patient.
It was. So the core philosophical shift is that successful resuscitation is measured not by how neatly you fix a structure, but by how effectively you preserve and restore normal physiology.
So this is the entire driving force behind modern concepts like damage control resuscitation, DCR, and damage control surgery, DCS.
Exactly. Strategies that are explicitly designed to stabilize the failing system first, and then you worry about the definitive repairs maybe 24 to 48 hours later.
Okay.
And this physiological focus is compounded by the fact that the torso, so our chest, abdomen, and pelvis, it's really a single interconnected unit. Injury seldom respects the artificial lines we draw between the thorax and abdomen.
Especially with blunt force trauma.
Oh, especially then. You get widespread internal shearing and compression.
That brings us to a concept that is just absolutely essential for every trauma learner, and that's the challenge of the junctional zones. These are the areas where the torso interfaces with its neighbors and where diagnosis just becomes exceptionally difficult.
Yes, these zones are high-risk crossroads. An injury there means you have to instantly assume damage in both regions. We identify 4 key junctional zones: the neck-thorax interface,
Okay.
the thorax-upper limbs interface, the thorax-abdomen interface, and then the abdominopelvic groin interface.
Let's unpack the 2 most problematic zones for torso trauma, starting with the physiological problem of the diaphragm, the muscle that separates the chest and the abdomen.
The diaphragm is a muscular dome, and its physiological movement is the key complication here. During expiration, so when you breathe out, the diaphragm can rise as high as the 4th intercostal space.
Which is roughly the nipple line.
Roughly the nipple line, yes. But during deep inspiration, it can descend all the way to the 8th intercostal space. So what this means is that any penetrating injury below the nipples, so somewhere between that 4th and 8th intercostal space, it must be investigated as if both the chest and the abdominal cavity have been entered.
You just have to assume it.
You have to. The risk of missing a life-threatening hollow viscous injury, like a perforated colon or stomach hidden high up under the ribs, is profound if you only focus on the chest.
That's the ultimate diagnostic insight for this region then. Assume penetration of both cavities, no matter what it looks like on the outside. Now, what about the pelvis? That structure is fixed, but it poses this enormous hemorrhagic challenge.
The pelvis is complex because it's bone protecting a massive non-compressible space that is just filled with a dense plexus of vessels. Specifically, the venous plexus there is extensive and completely unforgiving.
Right.
So if that rigid pelvic ring is disrupted, those vessels tear, and controlling the hemorrhage becomes exceptionally difficult because of the location and, well, the lack of surrounding tissue tamponade. Direct surgical access is deeply challenging.
So you can't just get in there and clamp it.
Not easily. So management often relies on controlling the volume of the pelvis itself and using adjunctive techniques like angioembolization to control arterial inflow, and then external binders or packing to control that more prevalent venous outflow. It's really an area where non-operative stabilization often has to precede definitive surgery.
Moving from the philosophy of control to the action of control, the foundation of immediate trauma care is, of course, the Advanced Trauma Life Support Protocol, ATLS. For anyone practicing trauma today, the hierarchy is clear, placing catastrophic hemorrhage control first. C, A, B, C, D, E.
And that initial C dictates everything we do in the primary survey.
Yeah.
You have to identify and control major hemorrhage before addressing the airway and breathing.
Because if the patient bleeds out, nothing else matters.
Nothing else matters. But here is the critical physiological caveat that every single clinician must know: the unreliability of traditional vital signs, especially in the young and fit patient.
This is a huge trap. The textbook warns us that fit, young individuals can maintain a deceptively normal clinical appearance despite massive internal blood loss. Why do they hide their injuries so well?
They have tremendous physiological reserves, and this is primarily driven by a massive surge of sympathetic nervous system activity. Their bodies launch an immediate, powerful vasoconstrictive response.
So they're clamping down.
They are clamping down hard. They can lose up to 30% of their total circulating volume, that's about 1.5 liters, while maintaining a near-normal pulse rate and systolic blood pressure.
They look stable, but they're not.
They look stable, but they are compensating maximally. They are right on the precipice. And once they reach the limit of that compensation, they crash. And they crash profoundly and rapidly, leaving you very little time to intervene.
So if those traditional indicators are unreliable in isolation, what are the true objective indicators we have to rely on to detect ongoing hidden bleeding?
We have to prioritize indicators of tissue hypoperfusion, not just heart rate. So you look for an increasing respiratory rate, tachypnea, and signs of, poor peripheral perfusion.
Clammy skin, that sort of thing.
Yes. And most importantly, we rely on objective markers like serum lactate levels. Lactate rises when tissues switch from aerobic to anaerobic metabolism because they're starved of oxygen. It's the true reflection of the body's debt and the extent of shock.
So a rising lactate confirms ongoing inadequate perfusion even if the patient's pulse seems fine.
Exactly. A falling blood pressure, on the other hand, is a late and dire sign. That indicates physiological collapse is already happening.
Once we suspect bleeding, the immediate next step is that systematic investigation using the famous mnemonic, 1 on the floor and 4 more, the 5 major sites of massive bleeding.
This is a mental checklist that ensures you miss nothing. 1 on the floor is external hemorrhage, which you have to immediately compress and control. The 4 internal sites are the chest, the abdomen.
And that critically includes the retroperitoneum.
Critically includes the retroperitoneum, yes. Then the pelvis and the extremities, like a massive thigh fracture.
The inclusion of the retroperitoneum in the abdominal site is so key. This is home to organs like the kidneys, the pancreas, and major vessels like the aorta and vena cava. Why is this area so stealthy and dangerous?
Because the retroperitoneum isn't part of the peritoneal cavity. It's this vast, non-distensible space defined by anatomical boundaries. Blood can collect there liters of it without causing the telltale signs of peritonitis or even obvious abdominal distension.
So the patient can bleed to death silently.
They can, unless you are specifically looking for signs of retroperitoneal hemorrhage like a flank hematoma, or you're relying on a high-quality CT scan in a stable patient. That patient can bleed to death before the symptoms become obvious.
Okay, let's pivot to the chest. We know thoracic injury accounts for about 25% of severe trauma. Thankfully, the vast majority, over 80%, can be managed non-operatively.
They can, often with just supportive care and a chest drain. The absolute key is early, correct diagnosis before that physiological collapse happens.
And that high non-operative rate really underscores the importance of the initial investigation hierarchy. Today, the EFAST exam sits right at the top.
It does.
So tell us about the EFAST Extended Focused Assessment with Sonography for Trauma. What is it looking for, and where does it fall short?
The EFAST is rapid, it's repeatable, and it's performed right there at the bedside. It's designed to detect fluid or air in key locations. Specifically, it assesses for cardiac tamponade.
Fluid in the pericardial sac.
Exactly. It looks for free blood or air in the chest cavity, so a hemothorax or pneumothorax, and free blood in the 4 standard abdominal windows. It's invaluable for triage.
But it has limitations.
Crucial limitations.
Oh.
It is highly operator dependent, it struggles to image the retroperitoneum effectively, and most critically, it has a low sensitivity for hollow viscous injury, or for excluding injury in penetrating trauma where bleeding might be minimal, but the contamination is severe.
And if the patient is just too unstable, bypassing radiology becomes necessary. What is the definitive on-the-spot procedure for that grossly unstable patient with clinical signs of immediate lung compromise?
That is the finger thoracostomy. This is a procedure that is simultaneously diagnostic and therapeutic, and it's reserved for a patient who is literally minutes from death.
So what do you do?
You make a small incision at the safe location, the 5th rib, just anterior to the mid-axillary line, and you bluntly dissect through the intercostal muscles until you enter the pleural space. Inserting your finger confirms entry and allows for immediate decompression of tension or confirms the presence of blood. It is rough, but it is fast, and in this scenario, speed saves lives.
Shifting to imaging for the more stable patient, what are the pitfalls of chest radiography?
Plain radiography is standard, particularly the AP supine view for the initial skeletal assessment. But in trauma, we have to be aware of its blind spots. The AP supine view is often suboptimal for revealing small pneumothoraces or fluid levels.
So an erect film is better.
An erect chest film is superior, yes, for detecting free gas and small fluid collections, but the patient has to be stable enough to sit up. The major pitfall, though, is that up to 300 milliliters of blood can be missed, pooling silently behind the domes of the diaphragm. You have to look at the diaphragms carefully.
And what about skeletal clues? Fractures that hint at deeper visceral damage.
The location of the bone fracture acts as a roadmap for internal injury. So fractures of the lower ribs, ribs 9 to 12, they correlate highly with damage to the organs they shield. The liver on the right and the spleen on the left.
Okay.
Conversely, fractures of the most rigid structures, the 1st or 2nd rib, or the sternum, that signifies massive, high-energy impact, and it raises immediate suspicion of an underlying thoracic aortic rupture or a tracheobronchial injury.
And if the patient is stable enough, the CT scan remains the gold standard for defining these complex injuries.
Yes. The CT scan with intravenous contrast provides that detailed 3D roadmap that's necessary for planning management, for assessing solid organ injury size, and for detecting retroperitoneal hematomas.
But it's not perfect.
It's not. We have to remember it's one key limitation in this context. While it's excellent for visualizing migration of abdominal contents into the chest or hernia, it can still miss an isolated, non-migrated diaphragmatic tear in the acute phase.
Before we jump to the operative steps, let's cover 2 common non-surgical thoracic injuries. First, the sucking chest wound or open pneumothorax. What's the rule for temporary closure?
The rule is precise. If you have a defect large enough to allow air exchange, you must not fully close it.
Why not?
Because closing it converts a manageable open pneumothorax into a deadly tension pneumothorax. The management is to apply a sterile occlusive dressing, but you secure it on only 3 sides. This creates a flutter valve.
A one-way valve.
A one-way valve, exactly. A temporary seal that allows air to escape during expiration, but prevents air from being sucked in during inspiration. And this must then be followed immediately by a definitive underwater sealed chest drain placed remote from the wound site itself.
And what about blunt bleeding, usually from small intercostal or internal mammary vessels?
Often it's self-limiting, just due to the musculature. If it persists, however, or if the patient requires persistent blood transfusion, we move to interventional radiology for angioembolization to stop the leak without open surgery. Operative ligation is really a last resort.
Now, let's confront the most critical list, the deadly dozen. We'll focus first on the 6 that have to be managed during the primary survey, starting with the most time-sensitive tension pneumothorax.
Tension pneumothorax represents a catastrophic mechanical failure. Air is trapped under pressure in the chest, it collapses the lung, and it pushes the entire mediastinum, including the heart and great vessels, over to the opposite side.
And that shift is what causes the shock.
It kinks the vena cava, preventing venous return to the heart. The result is immediate, profound obstructive shock.
The clinical signs are classic, but treatment can't wait for them all to manifest.
No, you look for restlessness, severe shortness of breath, and potentially distended neck veins. Tracheal deviation is a very, very late sign. The critical takeaway, which has to be hardwired into any trauma professional, is that treatment needle or finger decompression is based on clinical diagnosis alone.
Do not wait for an X-ray.
Do not wait. The delay will cost the patient's life.
Next on the list, pericardial tamponade. Small amounts of blood, but a massive effect.
Tamponade is typically caused by a penetrating injury. The pericardium is a fibrous sac that doesn't really stretch, so as little as 50 to 100 milliliters of blood can exert enough external pressure on the heart to restrict ventricular filling during diastole.
So the heart can't fill properly.
It can't, and stroke volume and cardiac output just plummet. While Beck's triad low blood pressure, raised central venous pressure, and muffled heart sounds is classic, we often rely on the EFAST scan for immediate confirmation in the trauma bay.
And the treatment distinction here is crucial. Why is pericardiocentesis, draining with a needle, useless here?
Because the blood that causes traumatic tamponade is usually clotted, or at least highly viscous. So a needle aspiration is just unlikely to extract the clot and release the pressure effectively.
So you have to open them up.
You do. The definitive immediate treatment is surgical. Open repair of the cardiac injury, access via a sternotomy, or a rapid left anterolateral thoracotomy.
Massive hemothorax. Let's define massive bleeding that requires immediate open surgery.
Massive hemothorax is defined by sheer volume. If the chest tube drains more than 1.5 liters, 1,500 ml of blood immediately upon insertion, or if the output is persistently high, say greater than 200 millimeters per hour over 2 to 4 consecutive hours,
Then you go to the OR.
then urgent thoracotomy is indicated. This tells you there's a major vascular injury, usually a systemic vessel or a pulmonary Hiller vessel, which needs surgical ligation.
And this brings us back to that crucial warning about the chest drain. Why is the old practice of clamping the drain to tamponade the bleed considered so dangerous now?
It is a legacy practice that is definitively rejected by modern guidelines. Clamping the tube allows blood to remain in the pleural space, which prevents the lung from fully re-expanding. More significantly, retained blood rapidly organizes. It leads to massive inflammatory responses, which causes either empyema infection or chronically a restrictive process called fibrothorax, which permanently limits lung function.
So the blood has to come out.
The blood must come out, period.
Finally, for this group, flail chest. It's a structural injury, but the physiological problem lies elsewhere, doesn't it?
It does. Flail chest is defined by 3 or more contiguous ribs fractured in 2 or more places. Crucially, the diagnosis is clinical. You see it as paradoxical motion. The segment moves inward on inspiration and outward on expiration.
But the breathing difficulty isn't from the floppy chest wall.
No, the respiratory distress isn't primarily caused by the flail segment. It's caused by the severe underlying pulmonary contusion. So, bruising of the lung parenchyma, which compromises gas exchange. That's the real problem.
So how does current management address that?
We no longer routinely put these patients on ventilators just to internally splint the chest. Current management focuses on aggressive support, optimizing oxygenation, rigorous pulmonary physiotherapy to clear secretions, and most importantly, achieving excellent pain control.
Pain control is key.
It is. Regional analgesic techniques like epidurals or intrapleural blocks are essential because pain relief allows the patient to breathe deeply and clear their own secretions. Ventilation is reserved only for those who develop refractory respiratory failure.
Moving beyond the immediate 6, let's briefly touch on the potentially life-threatening injuries, starting with thoracic aortic disruption.
This typically occurs at the ligamentum arteriosum following rapid deceleration, from high-speed crashes. The key physiological consequence is a tear in the intima and media of the aorta. Suspicion should be high if there is a widened mediastinum on X-ray, or, critically, if the patient presents with a systolic blood pressure differential of more than 20 millimeters of mercury between their arms.
And the initial non-operative management for a stable patient?
It's all pharmacological. You have to reduce the shear stress on that torn vessel. This means controlled blood pressure reduction, keeping the systolic pressure below 120, often using beta blockers. Definitive repair today is often endovascular placing a stent, as it's less invasive than direct open repair.
And And diaphragmatic injuries, let's just reiterate why the abdominal approach is preferred for a penetrating injury.
Right. If the diaphragm is lacerated by a penetrating mechanism, say a stab wound, there is an extremely high likelihood of an associated hollow viscous injury inside the abdominal cavity.
And the diaphragm tear itself isn't the immediate threat.
No, the mist contamination from bowel leak is. That's what will kill them. Therefore, we repair a penetrating diaphragmatic injury via a laparotomy, an abdominal approach to ensure a full exploration of the abdomen and rule out any associated bowel, stomach, or liver injury.
We've discussed these life-threatening injuries, but now we have to confront the ultimate decision point, the emergency department thoracotomy, or EDT. This is the situation of last resort. Why is the operating theater, the OR, always preferred, and what pushes a surgeon to actually operate right there in the resuscitation bay?
Well, the OR is preferred because it offers the optimal environment. You have full staffing, superior lighting, full anesthesia support, and the possibility of complex support like cardiopulmonary bypass or autotransfusion.
All the resources.
All the resources. However, when a patient presents in extremis, often after a penetrating injury, where their heart is stopped within the last few minutes, or where massive uncontrolled hemorrhage is happening, the minutes you'd spend transferring them to the OR are often fatal. That is when immediate rapid access via an EDT is indicated.
The indications for EDT are incredibly strict, aren't they? Precisely because the procedure itself carries immense risks and, frankly, grim survival rates.
They are. It was reserved almost exclusively for patients with penetrating trauma who have lost signs of life very recently, but who still demonstrate some electrical activity on the cardiac monitor. That shows the heart muscle is still potentially viable. For blunt trauma, the survival rate from an EDT is near zero, and it is very rarely justified.
And the futility criteria are essential for guiding that judgment. At what point does the source material suggest an EDT should be considered futile?
There are clear cutoffs based on the mechanism and the duration of downtime. So, if the patient has undergone CPR for more than 15 minutes in the setting of penetrating trauma, or more than 10 minutes in the setting of blunt trauma, the procedure is likely futile.
Okay.
Furthermore, if a patient with blunt trauma had no signs of life at the scene, an immediate EDT upon arrival is just highly unlikely to succeed. These criteria are grounded in the grim reality of outcome statistics.
And those survival statistics? They are brutal. They highlight how quickly the patient's status has to improve to justify the procedure.
Absolutely. Survival is heavily tied to the patient's initial blood pressure upon arrival, even after resuscitation attempts. For penetrating trauma, if the patient can maintain a systolic blood pressure greater than 60, survival can be as high as 60%.
That's surprisingly high.
It is, but once that blood pressure drops below 40, that rate plummets to just 3%.
Wow.
So this tells the surgeon that an EDT is a measure to gain time. It's not a guarantee of life.
And if the EDT is performed, it's not about complex repair. It has only 3 immediate life-saving aims. What are those priorities right there in the bay?
First, immediate hemorrhage control. That's often direct pressure or clamping to stop the heart or lung from bleeding. Second, internal cardiac massage, but only if the heart still has volume in it. If it's empty, massage achieves nothing.
Right.
And third, and perhaps the most complex maneuver performed in the bay, is clamping the descending thoracic aorta. This is done to maximize the limited remaining blood volume, shunting it up to perfuse the brain and the heart, gaining precious minutes for further resuscitation and transfer to the OR.
Let's assume the patient is stable enough to make it to the operating room for a planned immediate thoracotomy. How does the surgeon choose the optimal approach?
The surgical approach is determined by the likely injury. If the injury involves the heart's anterior surface, the ascending aorta, or the pulmonary arteries, the optimal approach is the median sternotomy. It provides wide access to the midline. For injuries to the left side of the heart, the thoracic aorta, or the left lung hilum, a left anterolateral thoracotomy is preferred. In severe cases, this left incision can be extended across the sternum to the right side, creating a clamshell incision, which provides the widest possible exposure for trauma, especially crucial if the diagnosis of the injury site is uncertain.
All right, moving from the chest to the abdomen, we enter a world of subtle danger. As you noted earlier, unlike peritonitis from a perforation, blood is not an irritant. Bleeding into the peritoneal cavity can be silent and massive.
That silence is the key clinical threat. Massive internal bleeding in the abdomen or retroperitoneum might initially cause only minimal discomfort. Distension might be subjective, and guarding or rebound tenderness might be absent at first, especially if the patient has other distracting injuries.
And a drop in blood pressure is, again, often a late sign.
A very late sign of profound volume depletion.
Therefore, the entire diagnostic workup really hinges on one crucial factor: patient stability after resuscitation. How does this stability dictate the extent of the investigation?
We use a triage system. If the patient is physiologically compromised, so unstable despite initial resuscitation, the investigation is aborted, and they go directly to the OR for emergency surgery. No delay.
Okay.
If they are non-compromised but still symptomatic, limited investigation is used to determine if they need operative versus non-operative management. And only if they are physiologically normal can we afford the time for the definitive, lengthy diagnostic workup like a CT scan.
Let's review the diagnostic toolkit, starting with simple plain films for penetrating injury. Why are they still useful when we have CT?
For penetrating trauma, plain films are vital for trajectory mapping. We place metal markers like bent paper clips on all entry and exit wounds. This lets the surgeon correlate the external holes with the trajectory of the missile or knife and to see if any foreign bodies are retained. This guides the surgical approach, which is particularly useful when you're searching for missiles lodged near major vessels or in the spine.
We've established the role of EFAST in the chest. How does its use in the abdomen compare, and what are its key limitations here?
In the abdomen, EFAST is excellent for detecting free fluid blood quickly. It reliably detects collections greater than 100 ml. However, its low sensitivity for subtle injury is a major concern.
Right.
It is unreliable for assessing the retroperitoneum, and most importantly, it cannot reliably exclude a hollow viscous injury. If an EFAST is negative, but your clinical suspicion remains high, you can't just discharge the patient.
Now, diagnostic peritoneal lavage, or DPL, is rarely seen in high-resource settings now, but it remains a historical benchmark. What was its decisive strength in resource-limited environments?
DPL was incredibly fast and binary. It involved placing a catheter into the peritoneal cavity and flushing with fluid. If you aspirated more than 10 ml of frank blood, or if the cell counts showed contamination, that patient immediately required a laparotomy.
So it gave you a clear yes or no.
A clear, non-subjective, actionable decision point where imaging was unavailable or too slow. And we have to remember its specific utility. If that lavage fluid subsequently drains out of an already placed chest tube, it immediately confirms a diaphragmatic perforation.
Now, for the stable patient, the CT scan. What makes it the gold standard, particularly for complex retroperitoneal and solid organ injury?
The CT scan with contrast is the unparalleled imaging modality for the stable patient. It accurately defines the extent of solid organ lacerations, liver, spleen, kidney, which is crucial for determining non-operative management criteria. Furthermore, it's the only reliable way to assess the extent of a retroperitoneal hematoma, helping the surgeon understand the potential source of bleeding before even making an incision.
And finally, what's the current role of laparoscopy in abdominal trauma?
Laparoscopy, or scoping the abdomen, is used predominantly as a screening tool in non-compromised patients, particularly after penetrating injuries like stab wounds. Its role is to definitively rule out a peritoneal breach or a diaphragmatic injury. By doing this, it significantly reduces the rate of negative or non-therapeutic laparotomies.
You avoid a big, unnecessary operation.
Exactly. Major surgeries that often cause more harm than good when no injury is found. If penetration is confirmed, however, many trauma centers will then proceed to a formal open laparotomy to ensure no small, easily missed injury like a tiny bowel perforation is left behind.
Let's delve into specific organ management strategies where the principles of damage control guide every decision, especially concerning hemorrhage. We'll start with the liver, one of the most commonly injured organs.
Right. Liver trauma is defined by whether it's a blunt compression injury, which causes fractures and lacerations in the parenchyma, or a penetrating injury, where the energy of missile can cause extensive cavitation and shockwave damage distant from the tract itself.
And the challenge is the vascularity.
It's highly vascularized.
Yeah.
And access to its deep vessels, the hepatic veins, is extremely difficult.
In the operative environment, the surgeon needs immediate tools for hemorrhage control. What's the operative strategy that's summarized by the mnemonic, the 4 Ps?
The 4 Ps are the immediate measures to stop bleeding until definitive repair or damage control can be achieved. First, pressure, often involving manual, bimanual compression to approximate the lacerated tissue.
Okay.
Second, the Pringle maneuver, which involves clamping or manually compressing the portal triad, the hepatic artery, portal vein, and bile duct, to temporarily stop blood inflow to the liver. Third, plug, which involves using specific materials or even silicone tubing to temporarily seal deep penetrating lacerations. And fourth, the most common damage control strategy, pack, where large surgical packs are placed around the liver to compress the bleeding surfaces.
The Pringle maneuver is critical, but it's a ticking clock, right? The liver can only tolerate that inflow occlusion for a finite amount of time.
Exactly. Pringle's maneuver can only be maintained safely for about 15 to 20 minutes before reperfusion is necessary. If bleeding recurs rapidly after you release the clamp, it implies a major injury to the retrohepatic vena cava or the hepatic veins, which requires advanced repair or shunt placement.
And when dealing with high-risk vascular injuries in the liver, there's a life-or-death distinction regarding which vessels can be tied off.
This is a point of huge importance. If the hepatic artery is damaged, it can be safely tied off or ligated because the liver receives sufficient collateral flow from the portal vein to survive.
But the portal vein is a different story.
A completely different story. The portal vein must never be ligated. Tying off the portal vein leads to massive bowel and splanchnic congestion, and it carries a mortality rate exceeding 50%. It must be repaired or shunted immediately.
Moving to the spleen. While non-operative management, or NOM, is preferred in children, how does that decision change for the unstable adult?
For the unstable adult, the priority is hemorrhage control, and the safest, quickest way to achieve that is often splenectomy removal of the spleen. While attempts at splenic repair or packing are sometimes undertaken in stable patients, if the patient is compromised, every minute counts.
And post-splenectomy, there's critical follow-up care.
That's right, and it must never be forgotten. Mandatory post-splenectomy care. The patient requires inoculation against encapsulated bacteria, specifically pneumococcus, within 2 to 3 weeks to protect against overwhelming post-splenectomy infection, or OPSI.
Next, the pancreas and duodenum. These are highly dangerous injuries because of their retroperitoneal location and the chemical contamination risk.
Yes, pancreatic and duodenal injuries are often missed early. Pancreatic injury is difficult to diagnose. Serum amylase is unreliable. CT is the mainstay. Management depends on duct involvement. Minor injuries can be drained. However, if the main pancreatic duct is transected in the tail or body, a distal pancreatectomy with drainage is the appropriate definitive repair.
But not a Whipple's.
No. It is essential to emphasize that the extensive and high-mortality Whipple's procedure is rarely justified in the emergency trauma setting. If the head of the pancreas is severely damaged, damage control packing, drainage, and temporary diversion is the strategy, with definitive, complex repair deferred until the patient is physiologically stable.
And duodenum injuries.
Duodenal repair depends on the location. Repairing the duodenum can be complex due to its proximity to the pancreas. Smaller injuries are repaired primarily. Major injuries, especially those involving the second part, the C-loop, require significant damage control procedures to divert bile and gastric contents and protect the repair. Again, complex reconstruction is reserved for the stable patient.
Let's discuss bowel injuries, the small bowel and colon. The risk here is overwhelming contamination leading to sepsis and acidosis.
The urgency is twofold: bleeding control and contamination control. For clean, isolated small bowel injuries, primary repair or resection with immediate anastomosis is possible.
But not in the damage control setting?
No. In the setting of massive contamination, shock, or multiple injuries, damage control is employed. This means temporary measures, using the clip-and-drop technique, temporary stapling of the bowel ends, or, particularly for extensive colonic contamination, creating a temporary defunctioning colostomy or ileostomy to divert the fecal stream, delaying anastomosis until the patient is stable and the abdominal cavity is clean.
Finally, renal and urological tract injuries.
For most renal injuries, so contusions and minor lacerations, the management is non-operative, provided the patient is stable. The exception is active bleeding on CT angiography, which is often managed by focused angioembolization via interventional radiology.
And the bladder.
For the bladder, we have to distinguish between intraperitoneal rupture, which requires surgical repair because urine spillage causes peritonitis, and an extraperitoneal rupture, which is almost always associated with a pelvic fracture, but usually heals well with prolonged, adequate transurethral catheter drainage.
We return now to the deepest, most dangerous source of hidden hemorrhage, the retroperitoneum and the pelvis. These areas can accommodate liters of blood without any external evidence, leading to rapid exsanguination.
This is where surgical judgment on whether to explore or avoid exploration is paramount. The retroperitoneum is divided into 3 critical zones, and the management strategy for the hematoma in each zone is the opposite of the others.
Let's clarify the 3 zones and their exploration guidelines. This is essential textbook knowledge.
Right. Zone 1 is central. This contains the aorta, vena cava, and pancreas. Any hematoma here is considered life-threatening and must always be explored surgically, but only after obtaining proximal and distal control of the major vessels outside the hematoma.
Okay, so zone 1, always explore. What about zone 2?
Zone 2 is lateral. This is primarily the renal area. Hematomas here, if they're non-pulsatile and non-expanding, are typically managed non-operatively. They are explored only if they are expanding, pulsatile, or if there is penetrating trauma.
And the third, the pelvic zone, zone 3.
Zone 3 is the pelvic retroperitoneum, and the rule here is to avoid opening the hematoma. Opening a pelvic hematoma without proximal control is a recipe for catastrophic, uncontrollable blood loss, as that plexus of vessels bleeds freely into the operating room.
So you don't touch it.
You don't. These hematomas are best controlled by non-operative external compression, extraperitoneal packing, or targeted angioembolization.
The pelvis itself presents an immense structural and hemorrhagic challenge. It takes extreme force to disrupt the ring, leading to massive blood loss.
And the anatomy here explains the danger. When the pelvic ring is disrupted, pried open like a book, the volume of the pelvic space increases dramatically. This extrapelvic space, which is loosely confined, can quickly accommodate over 3 liters of blood.
And that blood can track upwards.
It can track upward behind the peritoneum, sometimes reaching the diaphragm, a phenomenon known as the chimney effect. This hidden tracking means the patient is bleeding extensively without obvious localized signs.
And we rely on the tile classification to guide our stabilization strategy.
We do. The tile classification divides fractures based on stability. Type A fractures are stable. Type B are rotationally unstable. They can open like a book. And type C is completely unstable, full disruption, allowing vertical and horizontal displacement.
And the critical warning for examination.
Critically, in the emergency department, do not spring the pelvis by manipulating the iliac wings. This risks dislodging a clot and restarting a massive bleed.
So what is the single most critical immediate management step for a suspected pelvic fracture in the resuscitation bay?
The instant you confirm or even suspect a pelvic fracture, you need to apply immediate external compression. This means applying a trauma binder or a sheet, wrapped tightly and secured around the true pelvis at the level of the greater trochanters.
Why does that work so well?
Because that maneuver physically reduces the volume of the pelvic ring, which is the fastest way to control hemorrhage by providing mechanical tamponade to the bleeding vessels.
And we must reiterate the source of that bleeding. We often assume it's arterial, but the textbook clarifies the main culprit.
The vast majority, about 85% of the blood loss, is venous. It's from the lacerated venous plexus and the cancellous bone surfaces. This is why external compression is so effective. It compresses the low-pressure venous system.
So if that binding and external fixation fails, that's when you suspect an arterial bleed.
That's when we escalate to control the high-pressure system. That's when we bring in angioembolization.
So it's a multidisciplinary approach.
It has to be. Stabilizing the structure externally, packing internally if necessary, and using radiology to target arterial leaks. That is what defines successful pelvic trauma management. Early transfer to a center with this capability is essential if expertise is lacking.
We have referenced damage control, the DCS and DCR concepts throughout this deep dive. This philosophy, borrowed from naval engineering, is a strategic revolution designed to prevent the physiological failure of the patient.
It's the acknowledgement that if you try to achieve everything at once, you will achieve nothing. The driving threat is the deadly triad. The irreversible downward spiral of hypothermia, acidosis, and coagulopathy.
And they all feed into each other.
It's a feedback loop. Hypothermia exacerbates acidosis. Both together prevent clotting, which causes further bleeding, which leads to further hypothermia. It's a fatal cycle. Damage control is designed to break that cycle by minimizing time in the OR.
Therefore, damage control surgery, or DCS, isn't about definitive repair. It has 3 highly restrictive immediate goals.
Correct. The 3 goals of that initial abbreviated surgery are 1. Stopping active surgical bleeding. 2. Controlling gross contamination, for example, clipping bowel leaks. And 3. Restoring normal physiology by minimizing time and promoting warmth. The operation is suspended as soon as those 3 goals are met.
And this principle extends into damage control resuscitation, DCR, which fundamentally changes how we use the emergency department.
DCR means aggressive resuscitation, often starting in the bay, but achieving its bulk in the OR or ICU. It minimizes the time spent waiting for complex diagnostics. DCR is guided by real-time point-of-care testing, checking pH, lactate, clotting factors, and it focuses intensely on the early and aggressive delivery of biologically active fluids,
Meaning blood products.
meaning high ratios of blood products, packed red cells, fresh frozen plasma, and platelets, rather than relying on crystalloids, which just dilute clotting factors and worsen hypothermia and acidosis.
Let's walk through the stages of DCS, starting with the immediate stage 1 and 2.
Stages 1 and 2 are the abbreviated surgery itself. We use techniques like temporary ligation, shunting of major arteries, therapeutic packing of the liver or pelvis, and that temporary stapling of bowel injuries, the clip and drop. The operation is deliberately brief, often aimed for under 60 minutes, because core temperature drops precipitously in the OR, accelerating that deadly triad.
So the surgeon accepts a temporary solution to save the life.
Exactly.
Once that abbreviated surgery is done, the patient moves into stage 3 ICU resuscitation. This is where the physiological correction occurs before the definitive repair.
Stage 3 is absolutely critical. The patient is aggressively warmed, their ventilatory status is optimized, and most importantly, the coagulopathy and acidosis are fully reversed. Once the patient is physiologically optimized, typically 24 to 72 hours later, they return to the operating room for stage 3 and V.
And stage 4 and V is the definitive repair. But let's talk about how the abdomen is temporarily managed between surgeries. Surgeons use techniques like vac pack or ABSITE sandwich.
Temporary abdominal closure is non-negotiable in damage control. The goal is to manage the contamination and, critically, to prevent a devastating complication called abdominal compartment syndrome, or ACS. The vac pack technique involves placing plastic sheets over the bowel, placing packs over them, and applying gentle suction with a vacuum dressing. This pulls fluid out and protects the bowel while allowing the abdominal wall to recover.
Tell us more about abdominal compartment syndrome. Why must the abdomen be left open if there's any risk of it?
ACS is the result of massively raised intra-abdominal pressure due to tissue swelling, massive fluid schists, and retained packs. This pressure squeezes the organs, and critically, it elevates the diaphragm and impedes blood flow.
And the consequences are widespread.
They're systemic. Decreased venous return leads to low cardiac output. Renal vein compression leads to acute renal failure. And pressure on the diaphragm increases airway resistance, making ventilation difficult. If the surgeon suspects ACS, or if the abdominal fascia can't be approximated without tension, the abdomen must be left open, a planned laparotomy, to decompress the pressure and prevent a potentially fatal multi-system organ failure.
This has been a dense, high-yield deep dive into surgical essentials. The synthesized takeaway, which defines modern practice, is that trauma management is this highly disciplined, multi-stage race against physiological decline.
It is.
We have to employ swift, staged surgical interventions based on the patient's real-time stability, prioritizing immediate hemorrhage and contamination control over the definitive restoration of perfect anatomy.
Indeed. The core lesson of Bailey and Love here is that you save the life now with damage control, and you restore function later with a definitive repair. And to leave you, the learner, with one final provocative thought. Consider the growing acceptance of non-operative management, NOM, for solid organ injuries, the liver, the spleen, even in selected stable adults. We've seen that surgical repair is the ultimate control, but how have advances in diagnostic technology, specifically the ubiquitous use and increasing accuracy of CT scanning and the rise of interventional radiology like angioembolization, how have they shifted the risk profile?
That's a huge question. Has technology made NO the safer, preferred choice in an ever-expanding, carefully selected patient group, moving the surgeon from the primary decision-maker to the ultimate backup plan?
That tension between the speed of a surgical incision and the precision of a technological non-operative intervention is where the future of trauma surgery is constantly being debated and defined. It's a dynamic space that requires continuous critical thinking.
Something profound to reflect on as you take this knowledge forward. Thank you for joining us for the deep dive.